Dr. Kar are there? No. Okay. Then we'll start with the case presentation session. This is the oculoplasty and orbit case presentation session. The first case is listed to be presented by Dr. Lipsa Mahapatra on atypical case of thyroid associated ophthalmopathy. Is she here? Harshit Bansal? Okay. Dr. Ritika Goel? Yeah. She has a travel plan, so she's going to do first. Her case is case report of ruptured orbital hemangioma mimicking orbital cellulitis. Go ahead.
Good morning everyone. Let me tell you a story of a 18 years male who presented to our OPD with complaints of pain in left eye followed by swelling and blackening of left upper lid and diminution of vision, which was sudden in onset. It was associated with 3 episodes of projectile vomiting. There was no history of recent trauma, fever, headache or sinusitis or any other systemic illness. But they told that 5 years back he had trauma to left eye by fist, which was followed by swelling and redness of left eye. Since then, family members have noticed forward protrusion of left eye on lifting heavy weight, pressure over abdomen, sleeping in left lateral position, and during forward bending. These are the file photographs and videos which shows protrusion of left eye on applying pressure over abdomen. General and systemic examination was unremarkable. Visual acuity at the time of presentation was finger counting close to face. NCT could not be recorded due to swelling. Extraocular movements were limited in all gazes and grade 3 RAPD was present. Slit lamp examination shows blackening and swelling of upper lid and diffuse subconjunctival hemorrhage with chemosis. Rest all anterior segment examination was within normal limits. Posterior segment examination was unremarkable. IV antibiotics were started, followed by MRI brain with MR venogram, because at this stage we were suspecting it to be orbital cellulitis. And surprisingly, here was a miracle. Within 6 to 12 hours, the swelling subsided, chemosis reduced, visual acuity regained to 6/6. Extraocular movements were full in all gazes except some limitation in lateral gaze due to chemosis. Follow-up examination shows resolving chemosis, subconch hemorrhage present, pupillary reaction was normal. On day 2, IV antibiotics was stopped and patient was shifted to oral antibiotics. MRI brain shows hemangioma in left intracorneal space, proptosis of left orbit, lesion encasing the optic nerve, but signal intensity of optic nerve was normal. You can see fluid tracking along the left LPS, which is suggestive of rupture. Multiple blooming foci within the lesion, that is phlebolith. So a diagnosis of ruptured cavernous hemangioma was made. A follow-up MRI was done after 1 month to look for this progression of the hemangioma. After 5 months, when patient came for follow-up, he complained of mild forward protrusion of left eye during sleep. There were only 1 to 2 episodes which resolved spontaneously. We can see apparent enophthalmos, deep superior sulcus, and on valsalva, there was subtle filling at the site of superior circles. Herter's exophthalmometer reading at base distance of 30 shows right eye 20 mm and left 17 mm. So, the catch is here. Clinically, it is presenting like varix with intermittent proptosis, distension on valsalva, but on MRI, there is no evidence of any dilated veins, and it is a well-circumscribed lesion with molding and phlebolith. So, there is a confusion that whether we should tell it a hemangioma or varix. So, house is open for discussion, and I would like to get your inputs.
Any comments by anybody? See, actually, it looks like a case of venolymphatic malformation with a predominant venous component. Right? It behaves somewhat like a venolymphatic malformation, but also has the characteristic of a varices. But it is not a hemangioma because, as you showed on the MRI, it is molding on the eyeball. Hemangioma actually presses the eyeball. Here it is molding on the concave surface of the eyeball.
जी.
So this is more likely to be venolymphatic malformation with a predominant venous component rather than a lymphatic component.
Yes, sir.
And those patients do present with acute proptosis because of intralesional hemorrhage, which you showed very clearly, which spontaneously resolves as it happened in this patient.
Okay.
So yeah, that would be the diagnosis, most likely. Any comments from anybody? Raman? Okay. Vishal? Nobody? All of you do oculoplasty. Do you have any comments? Raka? Shalini? Okay. Yeah, so the best possible treatment even in venolymphatic malformation and predominant venous component is sclerosing agent. In a cold phase now that the patient is, you can inject bleomycin under, since it is mainly in the intraconal space with little bit of extraconal extension, you'll have to possibly do a CT guided bleomycin picibanil injection.
Okay. So, but already there is a component of inophthalmos. So, if we give
Then
this,
we can leave it alone. You can leave it alone. Explaining the
Yes.
patient
As
that.
of now, is on conservative management
All right.
and follow-ups.
Okay. Thank you.
Thank you, sir.
I don't know whether the next speaker is present. Lipsa Mohapatra. Harshit Bansal. Lipsa is here? Okay. She's going to present a case of atypical thyroid associated orbitopathy.
Good morning everyone. Today I am going to present a case of thyroid associated ophthalmopathy. Change नहीं हो रहा है. A 45-year-old Hindu female came to our ophthalmology OPD with chief complaint of watering right eye since 3 months with upward deviation of eyeball, pain and upward movement of eyeball. There is no significant past history. On ophthalmic examination, there is right eye proptosis, upward displacement of eyeball, restriction of eye movements on right eye in superior temporal and inferior temporal inferior quadrant. There is upper eyelid retraction and left eye hypophoria is seen in on-cover test. The patient is unable to converge both the eyes, and on exophthalmometry of right eye, the distance between the lateral orbital margin to the center of corneal reflex is 23 mm and of left eye is 18 mm. For the right eye hypertropia, the Parkes three-step test was performed. In first step, in primary case there is right eye hypertropia, and in second step hypertropia is increasing in right case and also increasing in right head tilt. This is the extraocular muscle movement before receiving the treatment. On examination of anterior segment, the conjunctiva was normal in both the eyes, cornea was clear, anterior chamber was within normal limit, pupil is reacting to both direct and consensual light reflex, and on lens there is NS grade 1 is present. The visual acuity of right eye was 6/18 and of left eye was 6/24, which was improving on P in-hole to 6/6. Intraocular pressure was 15 and 16 of right eye and left eye respectively. Color vision was normal. So what can be the other causes? My differential diagnosis are any maxillary sinus tumor or any optic neuritis, as there is painful in extraocular muscle movement was present, and or any left eye inferior oblique palsy. On investigation, there is on CBC microcytic hypochromic anemia was present. TSH was below the normal limit, that is less than 0.01. T4 was above the normal, that is 13.33 microgram percentage, and T3 was 1.82, and parathyroid hormone was within normal limit. The incisor brain orbit was normal. MRI brain and MRI orbit showing right eye bulky inferior medial superior rectus muscle and left eye bulky superior rectus muscle. So patient was received with tablet carbimazole 5 mg, injection methylprednisolone 500 mg for 5 days, injection pantoprazole and injection methylcobalamin. So hypertrophy of right eye was improved after 5 days of injection methylprednisolone, and also extraocular muscle movement was also improved after receiving the treatment. So my take-home message was early diagnosis and treatment can lead to better outcome. Thyroid-associated ophthalmopathy may mimic maxillary sinus tumor, so it should be kept in mind as differential. It is important to take radiography picture, blood thyroid profile for timely diagnosis and management, as there are different protocols for other differentials. Thank you.
Thank you. Any comments by anybody? Sir, Dr. Trisal, sir.
Hello. I think since they have done the thyroid profile and managed it conservatively, sir, how much these methylprednisolone is helpful? Is it really indicated?
Yeah. So, Vishal, do you want?
diplopia associated with it, and it doesn't resolve with this methylprednisolone 3 cycles as well, then we also chip in other immunosuppressive agents along with it.
You have to start with clinical activity score, either UGOGO or CAS, so that possibly was not done because you're not suspecting that the patient may have thyroid eye disease. It was a little atypical because it was mostly unilateral presentation, right? So unilateral presentation, especially in India, is about 30% of patients. When they present to you, it is unilateral. And over a period of time, they may develop symptoms and signs in the other eye. Even in unilateral patients, you have to suspect thyroid eye disease when there is lid retraction. There are very few causes for proptosis with lid retraction, one of which, of course, is thyroid ophthalmopathy, the most common, right? And after that, you have to do clinical activity score to know what is the level of activity and also determine the severity. There is a nice UGOGO classification which tells you what is the activity and what is the severity. In this patient, activity was mild, whereas severity was also moderate to severe. In such a situation, what you have done is right. Intravenous methylprednisolone has been given for 5 days, that's fine. But follow-up treatment is very important. Treatment doesn't end here, treatment only starts here. So you have to give 3 weekly cycles, or if you follow the UGOGO protocol, you have to give weekly cycles for 6 cycles and then reduce the dose to 250 milligram and continue the treatment, and immunomodulation as well. Otherwise, it will rebound. This is a disease that is not treated at one episode or one time. It has to be a prolonged treatment for 4.5 to 6 or even 6 months or even beyond. And finally, if she doesn't resolve, obviously, orbital decompression followed by extraocular muscle surgery, finally followed by lid surgery. That is only in the inactive phase. Any other comments?
To be done after the control of inflammation to some extent, or at the active phase itself?
Immunomodulation is, there are 2 ways of doing it. Either you follow the UGOGO protocol or the low dose IVMP protocol by Rootman. That which I feel is better in Indian circumstances, because we want to prolong treatment rather than cut the treatment short to 6 weeks. Our need for decompression is much less compared to Caucasians, right? So what we do is we start with intravenous methylprednisolone, 3 weekly protocol. At the end of 3rd pulse, when the patient comes for the 4th pulse, you assess activity and severity. If it is significantly resolved, then you don't have to start on immunomodulation at all. If it is not significantly resolved, then you start immunomodulation along with the 4th pulse of IV methylprednisolone, and you either give azathioprine or mycophenolate mofetil depending on the patient profile. That is continued for at least 6 months. Azathioprine dose that is followed is 50 milligram twice a day. Mycophenolate mofetil is 500 milligram twice a day, and that is given up to 6 months minimum. And then only you think of surgery, unless the patient has compressive optic neuropathy or corneal decompensation, where surgery can be done early. That is a protocol. And especially in smokers or young males, then the chance of rebound is much higher. Otherwise, in the West it is young females, but here in India it is the young males and smokers have the highest possibility of rebound. In them, possibly you have to prolong the treatment to little longer, if they don't give up smoking, that is. And selenium can also be added. Alcoholics, I really don't know whether it is it matters or not, but there is no such information. Thank you so much. Anybody? She was the first presenter in the list, sir. You
Okay.
can call anybody in the next.
Now, Dr. Harshit Bansal, Dr. Akriti Agarwal, Dr. Griselda Nongrim. Yeah,
Griselda?
Griselda Nongrim.
Yeah, please go.
A very good morning, everyone. On this beautiful day, I'm going to present my presentation, an unusual pencil tip injury. As we know, intraorbital foreign bodies can have varied presentation. A simple-looking injury can lead to severe consequences. Here is presented a case of simple-looking pencil tip injury leading to intracerebral granuloma formation. A 5-year-old girl presented with swelling of the right upper lid a month after pencil tip injury. She had received conservative management for the past 1 month after the initial injury. Her chief complaints were redness of the and swelling of the right upper lid, which was associated with headache. On inspection, the right upper lid swelling was seen, leading to ptosis. No visible pulsation of foreign bodies seen. No change on bending over or on Valsalva maneuver. On palpation, a firm mass is felt, which is non-tender, with overlying skin temperature slightly raised, extending from the medial canthal area to the junction of the middle 2/3 and lateral 1/3 upper lid. It is non-reducible, non-compressible, no pulsations were felt. The rest of the ocular examinations were unremarkable. On CT orbit, head and orbit, it showed 2 hyperdense shadows, one in the anterior orbit and the one in the frontal lobe. The latter was reported as a piece of fractured bone and the one in the orbit as pencil tip. Patient was treated conservatively on oral steroid and oral anti-epileptic as per consultation with the neurosurgeon, and patient responded well to treatment. On subsequent follow-up, which is 10 months later, there was spontaneous extrusion of the pencil tip from the anterior orbit. Extruded 2 small wooden bits were noted, which are less than 1 centimeter size. Few months later, 9 months later, patient again presented with the fullness of the right upper lid. After due confirmation that graphite in pencil is not magnetic, MRI was done and it showed blooming effect. Due neurosurgical opinion was again taken and conservative management was again advised. 2 years later, patient came back with similar complaints of tender swelling with signs of inflammation of the right upper lid. Exploration and excision of the granulation tissue was done. Intraoperatively, blackish soot-like material within the granuloma was found. Diagnosis of inflammatory granulation tissue was made on histopath examination. Patient was followed up at regular intervals. On subsequent follow-up months later, parents noted that the patient has alarming new symptoms of drowsiness and decreased activity and interaction among peers, along with behavioral changes. This prompted for repeat imaging. On CT, head and orbit showed both a granuloma, both on CECT and non-contrast, in the frontal lobe. Hence, with neurosurgical intervention was done, the frontal lobe granuloma required neurosurgical intervention and anterior craniotomy with deep exploration was done. The granuloma, which was again tinged with the same black soot-like material as in the previous orbit granuloma, was excised, and along with it, the offending pencil tip was found. There were no major postoperative sequelae and patient recovered well. In conclusion, this case highlights the fact that some simple-looking injuries can actually be life-threatening. Also, graphite in pencil is paramagnetic due to the silica which is in the clay component, which is added to harden the otherwise brittle and fragile graphite, and this can interfere with MRI by creating the blooming effects. Thus, pencil tip injury can cause chronic granuloma formation just like wood and should be removed as far as is possible. Thank you.
Very nice case. Thank you very much.
Thank you, sir.
Any comments?
That tip in the frontal lobe was first reported as a fractured bone. It was not reported as a pencil lid. So hence, as per the neurosurgical advice, we said that not to interfere with it. The patient is not having any symptoms as such. So if it is a fractured bone, it will not be creating any symptoms and all. So neurosurgery had advised not to touch it. So it was treated conservatively initially.
The first image was a CT scan. So obviously anything that is hyperdense is considered as fractured bone, and she had a defect in the roof as well. So this was a kind of a severe injury with the pencil which penetrated the roof and deposited the tip in the brain, which was possibly missed because initial MRI, initially CT was done, and later on MRI, when there was already a granuloma formation, blooming artifact can be there with the pencil tip as well because it is paramagnetic, and even in granuloma you see the same.
Yes, sir.
So it was a parallel kind of overlapping situation. Finally, the management was well done anyway. Thank you so much.
Any more questions? Okay. Thank you for your time.
Any more questions? Comments? First time you saw the case. Very good case.
Thank you.
Very educated.
Such a deep injury and there were no initial skin cut.
Skin cut must have been there actually, but it could be a very rapid kind of, some kid hits the child, it just goes in and comes out. The injury will be very small, few millimeters, and it closes. And these children, when they get into fights at school, generally don't tell their parents about the severity of the injury. They say, कुछ हो गया घर में, I mean, school में या friends के साथ लड़ते वक्त, but they won't actually tell the correct history. And if it's a small injury, the child is taken to a neighborhood physician or a general physician or maybe even a general ophthalmologist. They think it's a superficial injury and they say conservatively it can be managed. So it gets missed. The severity is actually missed.
Sir, I had a similar case, not in the brain of course, in the lead itself. A 2-year-old child had actually mass in the right upper lid for at least 6-7 months, and skin was fully normal. Mother didn't know. So when she came, when we wanted it, whole lead pencil was protruding out, and it was the base was incarcerated in the tarsal plate. So we had to remove it, and there was no symptom, nothing else. So actually, kids don't report until somebody suspects in the house. They never ever come to us, or we have to do the examination suspected that there is a foreign body.
Yes,
It can
because of
happen.
fear of
Pencil
getting
doesn't-
crashed, they underplay it.
Yeah.
Right. So they underreport it.
Another scenario, if there is a wooden foreign body, it gets almost missed in every CT scan that will. So in those cases also, this prolongs and the misdiagnosis will happen.
Baburam Govind, Dr. Baburam Govind, please.
Good morning to all. Today I am going to present a clinical case where it's a story of an intraorbital foreign body. This is a case of 45-year-old male patient who works as an accountant, presented with complaints of double vision and limitation of movements of left eye for a duration of 1 month. Coming to history of trauma to right eye lower lid on 5th of December 2023 while he was traveling in an open trailer of a truck where his head collided with a tree branch and a twig punctured into his right eye lower lid near to the nose. He was taken to a nearby hospital and primary management was done where the patient gave a history that the foreign body was removed and he was referred to the medical college. On arrival, his visual acuity was 6/6 and ocular movements were full and free in all gazes with normal pupillary reaction, digital tension and AC. X-ray face and CT brain was done which was reported as normal and he was posted on OT for the next day for wound exploration and there was no foreign body found and hence laceration was sutured and canalicular injury was repaired and on post-operative day patient was asymptomatic and discharged. He came with complaint of double vision and limitation of movements 1 month after on January 2024, which was more on looking down and left. There is no history of periorbital swelling in the left eye, diminution of vision, fever, headache, vomiting or painful ocular movements. General examination and systemic examinations were unremarkable with normal head posture, forehead, eyebrows and hair facial symmetry was maintained. We could appreciate an infected draining sinus over the medial aspect of right eye lower lid and HBCR was central. His best corrected visual acuity of both eye was 6/6 with a correction of plus 0.5 diopter cylindrical at an axis of 180 degree and a near add of plus 1 provided him a vision of N6 and NCT was 20 and 18 with pupils being normal and color and contrast sensitivity being normal. Ocular movements revealed a limitation of movement in superior levovision and on inferior gaze. And as depicted in 9-gaze photo also, we can appreciate a limitation of movements. A strabismogram was done which revealed a squint of 30 prism diopter in left hypotropia and a diplopia charting where the diplopia was more in inferior gaze and on levoversions. A Park 3 step was done and it revealed a involvement of left inferior rectus. A forced extension test was done, and we were unable to move the eye towards down and out, the left eye. Coming to the investigation, we did a review of CT where they have repeated a linear artifact in the left eye orbit. Hence, we moved to a MRI brain, which again revealed an linear artifact which was almost 4.9 to 0.5 centimeter, and with impingement of left inferior rectus, medial rectus, and inferior oblique. Hence, a diagnosis of elongated wooden body with the following measurements: puncturing the right eye lower lid, entering into the left orbit, causing impingement of left medial rectus, inferior rectus, and inferior oblique was made. Management: he underwent nasal endoscopic guided foreign body removal through the entry wound under GA, and a foreign body of the following measures were removed. On post-operative day 1, he was having a good vision of 6/6 with the near ad, and pupillary reaction were normal, and peculiarly the ocular movements were normal in both eyes. Thank you.
I think it's very well managed, extremely well managed.
Thank you, sir.
Yeah. ENT surgeon did it? Was it done by the ENT surgeon?
No, sir. It was removed by the ophthalmic surgeon itself.
And under endoscopic guidance?
Yes, sir.
Wow.
Under endoscopic guidance, through the entry wound itself, our consultant had removed the foreign body.
Very well done. Very well done.
Okay, regarding 9-gauge photograph, what happened to dextro elevation and levo elevation pictures?
Sorry, ma'am. It was taken just before the patient was shifting into the OT. It was in a hurry, so I couldn't take the 2 photos. At the time of injury, there was imaging done, sir, just as you told before. It was not picked up in the CT actually. Actually, we could have gone for an B scan also, because it was like if you haven't found something on CT, the imaging that as an ophthalmologist we could go for B scan also. But at that time, the patient also gave the history that the foreign body was removed from the outside hospital in pieces actually. So everyone was suspecting it's only a tract that was found at the acute stage. But he came back later. Since we were also lucky, the patient was also cooperative. He came back after 1 month to our institution itself.
Only thing is that you have to do a follow-on MRI after the inflammation subsides, because in wooden foreign body, conventionally it breaks into pieces. Even smaller, deeper pieces could still be there, although you have removed the main wooden.
Okay, sir. The later follow-up, the patient was actually normal.
Yes, symptoms-wise they will be normal, but like the child presented many years later, they may come back with an extruding small foreign body or granuloma formation.
Can be
So always a good idea to, once the inflammation subsides, maybe 3 or 4 months later, you can repeat an MRI and then see if there is anything residual at all.
Sure, sir. We will forward to that. Okay. Thank you, sir. Thank you very much.
Next speaker is Professor Shalini Kumari. Orbital floor fracture, method of presentation and customized approach of treatment.
Good morning. My topic is orbital floor fracture, myriad of presentations, and a customized approach of treatment. Through this case presentation, I want to highlight that as a surgeon, we always want to do surgery, do some surgical intervention, but sometimes it's better to hold back, do observation. So our patient, 34-year-old male, post road traffic accident 1 day ago, he came to us with swelling and pain in left eye. On examination, he had periorbital swelling, ecchymosis in left eye, and in ophthalmos was less than 2 mm. Vision was 6/6, no RAPD, no diplopia, and ocular movements were full and free in all gauges. Coming to palpation of orbital rim, it was normal, no crackling sensation, subconjunctival hemorrhage in left eye was noted. This is the ocular movement in all gauges. So the patient was seen in emergency department, airway, breathing, circulation was normal, and there was no episode of nausea or vomiting. We asked for CT scan of orbit, both axial and coronal curves, to rule out any fracture. Serial sequence of coronal section of CT scan showed fracture floor of orbit, the posterior extent of which turned out to be quite close to optic nerve on coronal section. This is the axial section. This is the 3D reconstruction. Since we have a CT facility in house, so we went ahead and looked for sagittal section also. The image is not over here. This report says multiple depressed fractures were noted in left maxillary antrum with the defect measuring approximately 1.2 mm to 11 millimeter laterally with soft tissue protruding into the antrum. Another fracture was noted in the floor of orbit with defect measuring approximately 5 mm with soft tissue structures and air loculi extending through the defect into maxillary antrum, causing mild impingement of inferior rectus muscle. This was a radiologist report. Depressed fracture was also noted in the roof of the orbit, and there was retro and periorbital soft tissue and fat strandings noted. So neurosurgeon's opinion was taken for fracture of roof of orbit. They said that no intervention is required. Regarding oculoplasty opinion, we wanted to do wait and watch as the risk of surgical intervention and subsequent possible complications with vision loss outweighs the benefit of restoring normal floor anatomy with implant, in this case in our hands. So we wanted to reevaluate after 2 weeks. Patient did come after 7 days for fundus examination, which was normal. When patient came after 2 weeks, periorbital swelling had subsided and in ophthalmos was almost nil. And this is the ocular movement post 2 weeks. On 3rd week, actually, since radiologist has said that there can be inferior rectus impingement, so we wanted to make it sure whether we want to intervene, and we'll just go for follow-up observation. We did a force reduction test for inferior rectus of the left eye, which was negative. So patient after 30 days was almost normal. This patient has been under our follow-up for last 6 months and is normal. So coming to literature review, we all know that myriads of presentations can be seen in orbital floor fracture cases, like they can be asymptomatic, or there can be cases of diplopia, enophthalmos, hypoglobus, hyposthesia, or sometimes entrapment of inferior rectus muscles. Regarding possible complications of surgical intervention in cases of orbital floor fracture, in certain cases, not in all cases, permanent loss of vision is also seen. Sometimes because of the direct deep insertion of the implant, impingement at the orbital apex, or retrobulbar hematoma. Now coming to clinical recommendations for repair of isolated orbital floor fracture, it is recommended that surgery can be taken within 2 weeks in cases of symptomatic diplopia with positive force reduction, and if there is evidence of orbital soft tissue entrapment on CT, or large orbital floor fractures that may cause latent enophthalmos. So the same study says that observation can be done in cases of minimal diplopia, not in primary or down gaze, with good ocular motility and with no significant enophthalmos, which approves our approach. There are articles which disapproves our approach, and so the take-home message is, in cases of orbital floor fracture extending close to optic nerve with soft tissue prolapse but with no restriction of motility or no diplopia or mild enophthalmos less than 2 mm, observation is a better approach compared to surgical intervention considering risk-benefit ratio. Thank you.
So, do you approve of the same thing? Say we should delay the intervention, surgical intervention, if there is no complication like diplopia or orbital nerve compression?
Yeah, we also follow this. Everybody follows, I think, the same approach. If enophthalmos is less than 2 millimeter, if the patient doesn't have hypoglobus of more than 2 millimeter, or there is no diplopia in any of the gazes, at least in primary gaze, then we start with oral steroids and review after 2 weeks. And if the patient has none of these, in fact, initially the patient may not have enophthalmos at all because of orbital inflammation and hematoma. Once that resolves, the patient may manifest enophthalmos and hypoglobus. So at the end of 2 weeks, we review once the inflammation component has subsided, and if the patient still doesn't have any significant enophthalmos, hypoglobus, and the orbital fracture is not large enough to cause it in the delayed setting, we do nothing. Otherwise, we immediately intervene and then do the floor implant.
If there is enophthalmos, we should.
Yes, if there is more than 2 millimeter of enophthalmos, or even less, if the patient is very keen on surgery, then we can definitely do. And in a posterior fracture, if the patient is keen on surgery, alleviation of enophthalmos and hypoglobus, we can simply repair the anterior and the middle portion of the fracture, and we don't have to put a deeper implant to cover the posterior extent of the fracture because there is no incarceration.
Thank you, sir.
Dr. Rajni Yadav. Dr. Ipsita Das. Dr. Ipsita Das has a topic on an unusual case of lower canaliculus laceration following dog bite managed by stent placement.
Good morning, everyone. I'll present an unusual case of lower canalicular laceration following dog bite managed by stent placement. The informed consent was taken from the patient and there was no conflict of interest and no financial support. Lower eyelid lacerations resulting from dog bites present a unique and challenging clinical scenario due to their delicate anatomy and potential aesthetic and functional consequences. A 19-year-old male presented to the ophthalmology emergency department with active bleeding from the medial canthal area of his left eye following a dog bite. The patient complained of epiphora, excessive tearing from the affected eye. On examination, the patient had a 2 cm 3 mm laceration at the medial part of the left lower lid area with injury to the canaliculus. Visual acuity was within normal limits in both the eyes. There was no signs of other ocular injury and the anterior and posterior segment of both eyes were within normal limits. The patient was diagnosed as a case of left lower lid canalicular laceration. The injury site was washed with adequate saline water. The patient was managed with conservatively initially with rabies immunoglobulin, anti-rabies vaccine, injection tetanus toxoid, oral antibiotic, oral analgesic, antibiotic drop ointment for local application. The patient was taken to operation room for repair. After local anesthesia, the wound was carefully explored to assess the extent of the injury to the surrounding tissue, including the canalicular duct. The 24-gauge cannula was introduced as canalicular stent in the affected lower canalicular duct. Syringing revealed full patency after the stent placement. The stent was fixed with the lower lid to avoid expulsion of the stent and irritation on the corneal surface. Primary repair of the left lower lid laceration was then performed meticulously to ensure optimal wound closure and alignment. The post-operative period was uneventful with no signs of infection or wound dehiscence. The patient epiphora gradually improved over the following weeks. The visual acuity remained unaffected. Patient was followed up at 2 and 4 weeks post-surgery with excellent cosmetic and functional outcome, and there was no watering from the left eye. The cannula was removed at 12 weeks post-operatively and syringing revealed full patency. The lower eyelid lacerations with canalicular injury due to dog bite are relatively rare, and early recognition and appropriate management are essential to prevent long-term complications such as chronic epiphora or lacrimal drainage system dysfunction. The use of 24-gauge cannula as canalicular stent followed by plastic repair of the lower lid laceration facilitated to restore the continuity of the duct and proper tear drainage. Eyelid lacerations with canalicular duct injury require prompt evaluation and surgical repair to prevent potential complications and optimize the patient outcome. This case report adds to the existing literature on the management of ophthalmic injuries and emphasizes the importance of providing comprehensive patient care. Thank you.
Use of 24-gauge cannula, since it doesn't have got that top like in mini Monaco tube, won't it protrude and then it will rub at the conjunctiva? That thing?
Actually, in a hospital setup, it is like more cheap and it is easily available. So, we used it, and the diameter of the canalicular is almost similar as that yellow 24-gauge cannula. So, it is like causing less harmful, minimally harmful for the canalicular. So, we used.
That we agree, because earlier when mini Monaco cannula was not available, everybody was using these stents. But then since it is available and it is not expensive at all, the Indian made one by Oral is very good, and it's not expensive.
Okay.
It provides internal fixation.
Okay.
Yeah, because it has this bulbous tip. It gets into the puncta and it gets fixed by itself, and it's very easy to insert as well. Yeah, so you could try using it because it's very easily available and inexpensive.
This cannula is very notorious for coming out. Even after 10 days or 12 days, the suture, anchoring suture gets loose, and the patient comes after 15-20 days, the cannula bahar aa gaya. So your whole exercise is...
Yeah, but if you use alternative mini Monaco, then this chance of extrusion that sir is mentioning is much less, because it is fixed anyway at the puncta. So it has a punctal plug.
Oh. Thank you.
So one more thing. So if there is a laceration like this, it is very difficult because there is edema and all that. It is very difficult to identify the medial aspect of the canaliculus, the sac part of it. So how can we help it?
There are many maneuvers. One is that you look at the wound after cleaning very nicely with an operating microscope under high magnification. More often than not, you'll be able to find out the cut end. Suppose it is not possible, put in a drop of phenylephrine. So there is pericanalicular blanching. It will look like a pale white cut structure. That is the one. If still you cannot make out, then there is modified Morrison technique where you pool saline in the medial canthus and inject air from the upper canaliculus. If even that fails, then there is this pigtail probe. Pigtail probe is quite traumatic, but the modified pigtail probe with a very gentle curve and a nice rounded tip that is available, you insert it from the upper canaliculus if the lower canaliculus is torn, and it comes out through the medial cuthead. So once you identify it, the job is nearly done. Threading the cannula is not a problem.
Just to add on to it,
You can use
fluorescein
fluorescein stain is also used.
Yes.
It stains the cuttage of the canaliculus. Also, you can inject a fluorescein tinged saline from the other canaliculus. But you should actually block so that it doesn't flow through the normal NLD, rather comes out through the cuthead. Thank you.
Thank you. Next is Dr. Vishal H. Sharma.
good morning everyone. My case presentation is on web of an overlooked injury. These are my associations, and I have no financial interest. Briefly introducing two fractures of orbital wall, common fracture sites of blowout fracture of orbit, that is shown in this red line, is the medial wall, medial and the floor of the orbit, just middle to the infraorbital groove, which is the thinnest part. And coming to this picture, it can be pure fracture, just a blowout fracture of the floor, and it could be impure, wherein the orbital margins can be involved. Mason and Culix classified the fractures based on the energy of impact, the degree and extent of comminution and displacement observed on CT. It could be a trapdoor fracture with a low velocity injuries, or a medial blowout fracture that is usually seen with the intermediate velocity of the injuries, or if the velocity is high enough, then it may cause lateral blowout fractures. So mode could be road traffic accident, domestic violence, assault, fall, or any trivial injury. So coming to the case, what is web of? It is white eye blowout fracture. So why it is important? So it has minimal signs noted on gross external examination, as you see in this child, and expected findings of lead edema, ecchymosis, or exophthalmos are absent. Subconjunctival hematoma may be present, and generally it is seen in pediatric age group. So why it is overlooked or rather underlooked? So in severe cases like head injury, as the patient is usually in the ICU setup, and in cases with milder injuries, with just a trivial injury around the eye, or if there is symptoms of head injury, generally patient thinks we think that it could be a symptom of head injury. So why prompt diagnosis is important? It may be fatal. So in this scenario, a 7-year-old male child presented with history of RTA, and he was rushed to the multi-specialty hospital due to multiple episodes of vomiting and syncopal attacks. CT brain was done, and with 5 mm cut sections and axial cuts, which was reported normal by the radiologist. He was treated conservatively by the neurosurgeon. After 4 days, still the persistence of the symptoms, the ophthalmologist was called in to take a review. So what do you see in this patient on this picture? There is a head tilt on the right side. Why is it so? Because there is limitation of up gaze. So this was a floor fracture with minimal inferior rectus tissue being prolapsed along with the orbital tissue into the fracture site, and which was missed on the CT scan on the with the higher larger cuts. So this is how force junction test was performed to see the limitation of the right eye, and this is to compare with the left eye the movement. The child was taken up for the surgery, and this is how the prolapsed tissue was retrieved from the fracture site. This is what the fracture site was seen, and it was repaired with the help of porous polyethylene implant. This is how we take the template with the help of a paper, and then we fashion it of the desired size and shape, and this is how the implant was placed. So at the end of surgery, we just confirmed the release of the muscle from the fracture site. This is pre-op. This is post-op day 4. Although intraoperatively we had the feel that we had retrieved it properly, we didn't find we did find some limitation in up gaze in this patient. This was because of the inflammation that was induced in this case. But at the end of 2 years follow-up, you can see the complete resolution of the limitation. This is just a slide which I want to emphasize upon the CT scan. A young female presented with subtle diplopia in down gaze associated with headache, nausea and giddiness. She had a fall in her washroom 3 days back, and her CT again came out to be normal as reported by the radiologist. Why? Because larger sections were taken. We should take at least a millimeter cut. As you can see in this case, there was only a 5 millimeter, less than a 5 millimeter bone fragment that was impinging to the inferior rectus, that caused the restriction, limitation and diplopia in this case. So my take-home message on this is, suspect whenever you have symptoms like nausea, oculocardiac reflexes, diplopia, dizziness, do suspect of orbital flow fracture. At least 1 millimeter size cut should be taken on CT scan in all the planes, axial, coronal as well as sagittal sections. And early intervention is the key to success in this. Thank you.
On a practical note, you said the early pictures showed that there is limitation of in the up gaze early because of the inflammation post 2 years. How frequently, I mean, since we are doing it regularly, how early does it come back to normal? Post of 1 week, you can think that still there is residual entrapment. 2 weeks means whether you'd like to intervene or you just wait and watch. What is your experience?
Usually, the movement comes back in early post-operative period.
How many
but
days?
the couple of days it can be seen. It's
that
not
picture was 1 week, no?
No, 4 days. In this case, there was a massive inflammation seen, and I repeated a CT scan, and I thought whether I need to intervene back again to open and redo the surgery. But as there was quite a edema seen on this scan, I waited. I gave him a short course of oral steroids for 5 days and stopped it, and the thing resolved on its own. So another take-home message for me was from this, that we should not directly jump into a resurgery in post-operative period if you see such kind of scenario with inflammation.
One question I have. after intraoperative, we have placed the implant and intraoperative force reduction test was negative. Now, after the surgery, when the patient comes to the outdoor after 1 or 2 days, then we see muscle diplopia. That is a complaint. Now, how long we will we'll just be quiet and put the patient on oral steroid or?
No, it is natural to expect diplopia immediately post-operatively
Yes.
because there will be trauma,
Yes, sir.
muscle sheath hematoma, muscle hematoma, inflammation in the area where you have intervened and retrieved the orbital contents and put an implant. You would expect it to resolve in 6 weeks to 3 months. 3 months is my outside limit. Beyond that, if obviously diplopia persists in primary position, then you have to go in for extraocular muscle surgery.
Fibrosis or something that have happened during the
Most
injury
likely,
or visit.
most likely. So you repeat a scan and then see if there is no prolapse of orbital contents with indirect incarceration or direct incarceration of the extraocular muscle. Sometimes what gets missed is the posterior edge of the fracture. If you don't explore it enough, the posterior extent of the fracture can be missed during your surgery. Right? So the end point of your exploration is visualization of the posterior extent of the fracture. That's very important. If you miss it, or if your implant sometimes can get displaced, especially if you use a implant such as porous polyethylene, which we all use, which is fixed by cyanoacrylate glue, can get displaced post-operatively. Whereas a titanium implant, since it is screwed, it doesn't get displaced. So if you have used such an implant, there's a possibility of displacement as well.
So that is one factor. The missed the posterior extent and we have not repaired, and second one, displaced implant.
Displaced implant. Beyond that, there is this direct muscle injury. Direct muscle injury can happen because of the trauma itself. Secondly, because of your exploration. You're exploring, right? And you're retrieving the muscle from a tight fracture situation.
Yes.
So in a child, white-eyed blood fracture, if the incarceration is very tight, you may have seen me enlarging the bony opening, enlarging the fracture so that the muscle comes off easily without you having to struggle.
Yes, sir.
Right? Once you enlarge the fracture, whatever that is incarcerated comes out very easily. This is specifically in a child with a white-eyed blood fracture, where the fracture is almost like a green stick fracture, where the displacement is hardly ever there and the fracture is very small and the incarceration is large. It's called a teardrop sign. That's because at the point of incarceration it is very narrow, but as it gets into the maxillary sinus it becomes like really bulbous. So that amount of tissue you have to retrieve from a very small fracture site, right?
So you have to enlarge it.
Yeah, you enlarge it. Anyway, you can put an implant. Thank you, sir.
Thank you. Next is Dr. Ritika Goel. She's finished. Now, next is Dr. Anantha Raina. She'll be pediatric preseptal cellulitis.
Good morning everyone. Today I am going to present my case on pediatric preceptal cellulitis, unusual case following rat bite in hilly region. The 11-year-old male presented in with IOPD with chief complaints of painful marked swelling of left eyelids for 5 days, blackish mark on periorbital region and fever at presentation. History of present illness was that the patient was apparently well 5 days back when he experienced painful marked swelling of upper and lower eyelids when he woke up in the morning, which was sudden in onset, progressive in nature, which was associated with black scar mark on the lateral part of the upper eyelid, and upon instigating the patient, parents revealed the history of rat bite 11 days back, which was initially neglected. Then the patient was made visit to the local hospital, and they treated the patient with oral antibiotics, topical antibiotics and oral painkiller, but there was no improvement observed by the parents. So they rushed to the our hospital. Past medical history, patient had no significant past medical history. Personal history where patient was non-vegetarian and the rest was within normal limit, and family history was not significant. On general physical examination, everything was normal except the patient was febrile and pulse rate was higher. Ocular examination was done in which it was found that the major findings were that in ocular adnexa of left eyelid, there was a significant lid edema, blackish necrotic wound laterally in the upper eyelid, which was tender and febrile. Ocular movements were full and free in all cases in both eyes, and particularly when pupil was checked, there was no sign of any RAPD, and rest was within normal limit. In conjunctiva, subconjunctival hemorrhage was seen, and these are the pictures of rat bite with necrotic wound and the periorbital lid edema and subcons hemorrhage in the left eye. The provisional diagnosis made was a left eye preceptal cellulitis. After that, diagnostic workup was done, in which then ESR was significantly high and imaging was done by using CT scan of left orbit. These are the CT images of axial scan showing pre-orbit hyperdense areas depicting soft tissue swelling in the left periorbital region, which was consistent with the pre-septal cellulitis. These are the coronal scans showing the hyperdense areas of enhancement anterior to the orbital septum. Rest was all normal in left periorbital region. Diagnosis made was left eye pre-septal cellulitis with rat bite. For this, management was done. Initial treatment was anti-rabies virus and TT was done, and then patient was admitted in the hospital with he was treated with injectable broad spectrum antibiotics for 7 days, and topical eye drops were given to the patient. Then oral medications were given. The wound was regularly cleaned and lid hygiene was done. Regular follow-up was done to monitor for the signs of orbital cellulitis. These are the follow-up pictures of the patient while in the hospital admission. So such cases are generally unusual presentation. There is incidence of pre-septal cellulitis due to rat bite, but it is very uncommon. It can be unique in hill areas due to increased rodent exposure and limited access to the healthcare. Complications, if we leave untreated, the patient can lead to orbital cellulitis, and vision loss can also be present. So I would like to recommend all the health care providers to maintain high index of suspicion and promptly mitigate the risk. Action was taken promptly, and the key takeaway is that the pediatric pre-septal cellulitis can arise from uncommon causes like animal bites, or increased awareness is critical for timely intervention. We should emphasize necessity for thorough evaluation in any eyelid swelling, especially after animal bites. So in pre-septal cellulitis, it is important that we treat the patient immediately and regress rapidly, so that the patient cannot go for serious consequences. Thank you. Thank you.
Any questions? This is for the first time I have heard that rat bite leading to orbital cellulitis. Most of the times it's the limbs that are attacked, but unusual case, but managed nicely with antibiotic. Obviously, it was a rat bite, and orbital cellulitis it was a usual outcome. Okay. Any questions? Thank you.
Thank you, sir. Thank you.
Next is Dr. Raka Chatterjee. Simultaneous eyelid and conjunctival melanoma.
Good morning, everybody. I shall be presenting one interesting case where there was a malignant melanoma, simultaneous occurrence in ipsilateral eye in both eyelid and the conjunctiva. A 37-year-old male patient presented with a black pigmented mass at the inner angle of the left eye since 1 month, which was slowly progressing, painless, non-itchy lesion and not bleeding to touch. There was no other significant past ocular morbidity, systemic illness or drug history. On clinical examination, the best corrected visual acuity in the right eye was 6.9, left eye was 6.6 and near vision was in 6 in both the eyes. There was a black pigmented mass at the medial canthus of the left eye, which was around 7 mm by 3 mm in dimension along the leads, with full thickness involvement, and the conjunctiva including the caruncle where it was about 7 mm by 4 mm. It was an elevated, non-mobile, non-tender lesion without any feeder vessel. There was no lymphadenopathy on palpation. Extraocular movements were full in all directions in both the eyes, and the fundus was within normal limit. Intraocular pressures were also normal. This was a diagrammatic representation of the lesion as I saw, and it was a contiguous lesion, meaning the conjunctival lesion was continued to the eyelid, lid margin lesion. So we went for a CECT orbit. The study revealed only bilateral maxillary sinusitis. I wanted to do this CT scan just to rule out any orbital involvement, because though clinically I was not suspecting anything, but I did it. USG abdomen was also normal. Then we went for the required pre-operative tests, some of which also were to see whether is associated distant malignancy, if at all the lesion, the pigmented lesion, comes out to be a malignant lesion. So in a dilemma whether the lesion is a simple nevi or is a malignant dead limb melanoma, I plan to do an incision biopsy from skin and the conjunctival lesion separately. And this was the report from the incision biopsy, and where from both the lesions, both the sides, the reporting was malignant melanoma eyelid, where the base was involved, and the conjunctival lesion was a melanoma in situ. The definitive management was left eye, the excision biopsy of the conjunctival lesion with 4 mm margin with cryotherapy and with amniotic membrane transplantation, plus excision biopsy of the eyelid lesions with 4 mm margin and lid reconstruction under general anesthesia under frozen section guidance. Now few snips of the procedure as you see here. This is the lesion. This is the lesion after excision of the lid and the conjunctiva, and you can see the excised lesion. The dimension was quite big when we took with the margin. Now putting in the AMT, see the second stage, third stage, I put it with the fibrin glue, tissue glue. And this was the case after excision of the whole mass, and post-operative results were satisfactory. This was immediate post-operative after 3-4 days, and this is the little chemosis was there. The last picture is after 1 week. Histopathologically, the diagnosis was confirmed, and we have achieved the margin clearance. Then I had sent the patient to the Department of Radiology for further management if anything at all was required, but they didn't do anything. I am following it up for last 6 years and revealed no recurrence, and patient is otherwise fine, living a healthy life. In conclusion, the bulbar conjunctival melanomas are quite common. Extension of the conjunctival melanoma into the eyelid can occur in 1% of the cases. Cases of simultaneous non-contiguous melanomas are very rare. My case was a case of melanoma with a contiguous lesion. Excision biopsy with margin clearance and the cryotherapy is the mainstay of treatment here. Though in isolated lesions of bulbar conjunctival melanomas near cornea like limbal lesions etc., we do alcohol epitheliokeratectomy as well. Local recurrence is common in 10-year follow-up. Thank you. All along, depth it is a full thickness. I didn't. Yes, clinically where I saw, and it was a little, see the conjunctival lesion was little more horizontally, so my excision was more from the conjunctival side and posterior lamella rather if I say it, whereas the skin lesion was little smaller. So even with the margin, the skin defect was smaller than the conjunctival defect. So it was a differential excision and differential lid reconstruction. And conjunctival lesion, so I had put the AMT to make up the gap. And for the lid, though, I had just a direct closure was enough because the lesion was not that much to do something like canthotomic antholysis, etc.
So you did that pentagon excision towards the lead side?
Lead side.
Okay. and that side one.
That's
Any
it.
pre-op investigation to determine the depth so as to plan your exit? Sometimes it can extend.
No.
beyond
I had done only a CT scan, CECT, to know the depth into the orbit, but clinically extraocular movement was full. So I have never suspected that it will go inside, but still I did it.
Any other questions?
And margin of the conjunctiva as well.
So the trick is suspect and treat early, because this patient didn't need any radiotherapy luckily, and she was okay till 6 years follow-up. Thank you. Dr. Sanjana. Dr. Surabhi Kumari. Last is Dr. Shri Jandeep Kumar.
Good morning everyone. I am going to present a case of upper eyelid coloboma managed with Tangel flap technique. Eyelid coloboma is a congenital defect of the eyelid margin that results from incomplete fusion of the embryonic fissures. It can cause cosmetic deformity, exposure keratopathy, corneal ulceration, scarring, neovascularization, and thereby visual impairment. The treatment of eyelid coloboma depends on the size and the location of the defect, the condition of the ocular surface, and the patient's preference. My case, a 27-year-old girl presented with upper eyelid defect in the left eye since birth, with corneal opacity and subsequent diminution of vision since childhood. Corneal opacity developed following a history of red eye ache, and discharge at the age of 4 years. There was no history of any ocular trauma or ocular surgery. No history of any systemic comorbidities was there. On examination, she had upper eyelid coloboma medially, which was around 12 mm in length, causing 50% defect in lid margin. There was exotropia of the left eye. Visual acuity in the left eye was finger counting close to face, and right eye was 6/6. IOP by Sears was 10.4 mmHg of left eye. Extraocular movements were full, free, and painless in all directions in both eyes. There was adherent leukomatous corneal opacity of 4/4 mm in dimension, with superficial neovascularization of cornea at the exposed part and shallow anterior chamber. USG scan of the left eye was normal. Now my patient was diagnosed as a case of congenital upper eyelid coloboma with leukomatous corneal opacity and sensory exotropia of left eye. Patient was initially managed with antibiotic eye drop, lubricant, and oral antibiotic. Eyelid coloboma reconstruction by direct appositional closure with Tangel semicircular flap was done. Here a carved incision was made at lateral canthus, extending it laterally, creating a semicircular flap from the lateral canthus. Then flap was mobilized medially. It was sutured with the defect margin. The donor side was closed with interrupted sutures. The patient had an uneventful postoperative recovery after eyelid coloboma reconstruction. The patient had improved eyelid function, cosmetic appearance, and ocular surface protection. Now this is the picture showing the patient before the surgery and 3 months after the surgery. The patient further planned for cosmetic penetrating keratoplasty and exotropy correction for cosmetic purpose. Eyelid coloboma reconstruction by direct appositional closure with Tangel semicircular flap is an effective technique for medium-sized defect. Our case reports adds to the existing literature to the management of eyelid coloboma. The aim of this study was to report a case of upper eyelid coloboma that was managed by eyelid coloboma reconstruction. We achieved good functional and cosmetic result for eyelid. We suggest that eyelid coloboma reconstruction by direct appositional closure with Tangel semicircular flap is an effective technique for medium-sized defect. Thank you.
Any questions? I think 50%, up to 50% of the lid coloboma, if it is a 50% defect, it can be done by the direct apposition, and anything beyond that probably we will need a flap graft. So they have done it's a simpler procedure and less time consuming, so nicely done, and they have followed it up with PK and cosmetic surgery, so a good cosmetic. Any questions from the audience?
Thank you, sir.
Thank you. I think we have come to the end of the session. Thank you everybody for being present. Thank you.